Good afternoon, everyone. I'm Taimur. I'm one of the Jackson Memorial Hospital Internal Medicine Chief Residents, and it's my honor to introduce today's first speaker, Dr. Priscila Barreto. Dr. Priscila Barreto is a breast medical oncologist and assistant professor at the Sylvester Comprehensive Cancer Center at the University of Miami, where she also serves as the associate director of the Global Oncology Program. Originally from Brazil, Dr. Barreto brings a deep commitment to health equity and global cancer research. She completed her hematology and medical oncology fellowship at Jackson Memorial Hospital and Sylvester, where she cultivated the strong foundation in patient-centered care and disparities-focused research. Her clinical and scientific focus centers on improving outcomes for women with hormone receptor-positive, HER2-negative breast cancer, particularly among Black and Latina populations who face disproportionately worse outcomes despite receiving standard of care therapies. Dr. Barreto leads multiple research efforts investigating how hormonal, inflammatory, and genomic factors influence differential responses to aromatase inhibitors. Her work includes prospective clinical studies that integrate biomarker analysis, next-generation sequencing, and spatial transcriptomics to uncover mechanisms of resistance and guide precision treatment approaches. She has published in high-impact journals such as JAMA Network Open and Breast Cancer Research and Treatment, and has presented at national and international conferences, including ASCO and CTOS. A recipient of the ASCO Young Investigator Award and Early Career Researcher of the Year, Dr. Barreto is also a former JCO Oncology Practice Editorial Fellow and an active advocate for increasing diverse representation in clinical trials and translational research. Please welcome Dr. Barreto.
Hello. Hi, can you hear me? Yeah, it's okay. Okay, so first of all, I want to say how happy I am to be here. I did my residency and training all here at Jackson, so I've always been on the other side. So it's my first time that I'm here on this side. So thank you for inviting me. I think the presentation here already gave a little bit of what I'm going to talk. That is the disparity crisis in breast cancer. How doesn't the mouse? Okay, so I think it's always good when you're going to do a talk like this that I'm talking to a lot of people that are new on this. Why it's important for me to be here talking about breast cancer, right? So I like to start with some numbers. So breast cancer is the most commonly diagnosed cancer among women, both in developed and less developing countries. It corresponds to 1 in all 4 cancers of women around the world. And the numbers are really high. So in 2020, we had more than 2.26 million new cases of breast cancer in women and more than 680,000 deaths related to that. Incidence in breast cancer has been increasing throughout the years, and we have numbers such as 1 in every 11 women to be diagnosed with breast cancer from 1975 to nowadays to have 1 in every 8 women. So if you look around here, if you count 8 friends of yours, 8 women, 1 of them is going to be diagnosed with breast cancer. And as we all know, the probability will increase as we age, being highest among women that are older than 70 years old. And in the US itself, we had more than 280,000 cases of invasive disease in 2022, and more than 43,000 deaths related to breast cancer, corresponding to 7.1% of all cancer deaths. So, but I need to be fair here. While I'm talking about these very shocking numbers, mortality due to breast cancer has been improving throughout the years, and that's mostly due to the development of new drugs and the multidisciplinary care that we give our patients, diagnosing early and giving better care to our patients. So, but here I want to talk about the disparity crisis, because what happened is that the improvement has not been the same pace between both Black and white women. So what is this disparity here? We're having the outcomes that are improving, but the benefits are not equally distributed among the population. So here, these 2 graphs from the ACS here that I want to talk about. We see here in the lighter pink corresponds to Black women and the darker pink to the white woman. And we see that the survival has been increasing, but look at the gap that exists is still with Black women dying much more of breast cancer than white women. And we see that the incidence is fairly the same, but it's just the mortality that has been different. So when we think about worldwide, the numbers will look different, right? So if you're going to see the countries that will have the highest incidence of breast cancer, they are different than the ones that have the highest mortality due to breast cancer. While we have the higher incidence in countries such as the US, Australia, we also have very high incidence in Europe, such as Belgium, and we have high mortality rates in different countries. High mortality rates are happening in Africa, countries such as Somalia, Mali, but also in the Caribbean. So what are the goals here of my talk with you all? I want to discuss why there are disparities in breast cancer. We're going to talk a little about race, ethnicity, ancestry. We're going to talk if all our patients are receiving the same treatment and what are the differences in response to the common treatments that we have and where we can intervene. And here I put a picture of Matryoshka doll because I just want to highlight that I've been working with disparities in breast cancer for the past 8 years, and it has been like that for me. Every time that I find something, I find out there is a million reasons behind that. So we just continue uncovering and covering more reasons for that. So the reasons for disparities are very complex, and I usually call them pieces of a puzzle. So that means all of them are equally important. You cannot form a puzzle without one of those pieces. So we have reasons such as income, the implicit bias, mistrust of health system, meaning like socioeconomic factors that we have. We have also barriers to screening, but we also have other differences, such as difference in treatment, but presentation being different. These patients are having different biology and different genetics. So we need to think about all these pieces of this puzzle because they are important to be all addressed to decrease the disparities that we saw. So the Dana-Farber in 2018, they got this data from the NCDB and they were like, okay, let's look at all these women being diagnosed with early stage breast cancer. Let's take a look at them and see what are the factors that are contributing to the different outcomes. And they saw exactly that. There's not only one factor. We see a lot of them. We see tumor characteristics, we see different treatments, we see comorbidities that are different, and we also see demographics. So first thing that I want to talk is the different biology that these tumors have. So breast cancer is not all the same. So breast cancer has different groups, and how we characterize breast cancer differs a lot, depending if they are hormone receptor positive, if they are triple negative, HER2 positive breast cancer. And we see that different populations, they have different types of biology of breast cancer. Black individuals, independently of their country of birth or residency, they disproportionately develop more aggressive subtypes of cancer. They have more triple negative breast cancer, they are diagnosed at a younger age, and they have more advanced stage of diagnosis. So what do these all Black patients they have in common? It's their ancestry, right? So they all share this similar genetic background. That's why we're seeing what we're seeing. So the origin of these ancestral backgrounds are involved in the incidence and mortality of Black women with breast cancer. And we need to talk here about the importance of this Africa diaspora. So the Africa diaspora was this worldwide collection of communities that descended from Native Africans and people from Africa. So all these populations, they were from Western and Central Africa, and due to the transatlantic slave trades, they were moved here throughout the Americas and the Caribbean. So we need to understand who are the women, who are the Black women that we have here in the U.S. So it's very interesting that 47.2 million in the U.S. self-identified themselves as Black in 2021, and that was a 30% increase over the past 2 decades. And from this 47.2, we have 10% of immigrants here. So we're talking about a lot of these Black patients, they are immigrants and not exactly African Americans born here. And Florida, I want to highlight, is the second largest population of immigrants in the US. It comes only behind New York. So we started here due to our close proximity with the Caribbean, we started to take a better look at that. And the Caribbean is a very interesting place to study because of this whole ancestry. And like I mentioned before, it has this very high mortality. But it's interesting because it's in this intersection with North America as well, because it also has a high incidence of breast cancer. So the Caribbean is a very interesting place for us to talk about because it has the highest mortality to incidence of breast cancer, and we have countries such as Barbados and Jamaica with the highest rates of breast cancer of the region. Due to these findings and having a lot of this population being seen here in Jackson, my mentor, Dr. Hurley, and her team at the time, this was in 2011, they started to notice that these women, they had more aggressive breast cancer. So they started to do genetic testing on them. And what they found was a high prevalence of BRCA mutations among breast cancer patients from the Bahamas. And 24 to 28% of the Bahamian women with breast and ovarian cancers were found to have the deleterious mutation in the BRCA1 gene. And that work led to the NCCN guidelines to actually recommend and have a full recommendation for all Bahamian women diagnosed with breast cancer to need to have genetic testing for a BRCA mutation. But like I mentioned before, like a matryoshka doll, so she opened the first doll, right? So it came more. So they started to look at other islands of the Caribbean. So they saw that each island had their own set of mutations and particularities. So, for example, Trinidad Tobago was found to have 10.4 mutation, at least one of the genes, BRCA1, BRCA2 of ALB2, and Jamaica had 4.5 mutation, at least one gene, with the majority being PALB2. So later, when I was already working with them, we got together and we did a compilation of all these studies, but we also did an expansion. And what we found, we included 6 Caribbean countries, and we saw that Caribbean-born individuals had higher rates of breast and hereditary ovarian cancer, with 1 in every 7 Caribbean women to have a deleterious BRCA1 or 2 mutation. That number is much higher than what we see in the general population, that it's about 1 in every 400 to 500 women to have one of these mutations. So 23% of breast and ovarian cancer in the Bahamas was found to be hereditary, being 4.9% in the Jamaican. And it was interesting because we saw exactly what I said before. Each island had their own set of variants. So later we said, okay, so what about here in Florida? We have not only the American population, these born individuals here, but we also have a lot of immigrants, but also the daughters and the sons of immigrants, right? So we wanted to see if the place of birth exerted any impact of mortality. So we actually saw that Caribbean-born patients had a better overall survival compared to African-American women. And we were looking here at the same healthcare system and the same access, right? So then we came to the conclusion that the Black population is not monolithic, right? All these patients, they have very different ancestry and genetics. So we need to understand their origin and ancestry in order to provide them the better care that they need. But like I mentioned before, it's a puzzle. So I talked here a little bit about the difference in biology, right? But I also want to talk about what is the impact on delivery care. So I wanted to bring up this graph here that shows deaths from breast cancer in the past 50 years in the US. And we see that back in the 70s and the 80s, death in Black and white women is fairly similar, and the curves actually, they crossed themselves. And we need to understand that the treatments at that time, they were not that good. We were not diagnosing as well these patients. But as we got better in treating patients, we saw that the gap was increasing, right? So there's clear a problem here with the delivery of care that we're giving to these patients. Okay, so there is clear treatment selection, right? There is a lot of report about adjuvant chemotherapy and how adjuvant chemotherapy has not been administered equally among races and ethnicities. Adjuvant therapy is a modality that changes how these patients are going to be treated, and it's very important. And what's been reported in the literature is that Black patients are more likely to receive non-standard regimens, lower chemo doses, and lower relative in dose intensity as well. So I talked a little bit about triple-negative breast cancer, but I want to bring here HER2-positive breast cancer. So HER2-positive breast cancer has been a type of breast cancer that the way that we treat this woman have changed a lot because we have the development of these drugs that are targeted therapies, right? So nowadays we have, for example, trastuzumab that completely changed how these patients are living. And the University of North Carolina, they decided to do this study using Medicare data, meaning like older patients. And they were like, okay, let's see if all these patients are receiving the appropriate treatment and if there is any type of disparity. And they saw that anti-HER2 therapy was ultimately given to Black patients. But later, the Dana-Farber group, they decided, okay, but this data is with a lot of these Medicare patients. We don't know about their comorbidities, what's going on. Let's take a look at the NCCN database. So the NCCN database is the National Cancer Database with clinical trials. So we're talking about all these patients that are in an ideal setting, right? We're talking about young patients being enrolled in clinical trials. Let's see if there is any difference here. And they didn't see any difference on the trastuzumab being given to the patients significant to race and ethnicity. But what they did see was that the Black women were less likely to complete therapy. So trastuzumab is usually given to patients for about a year, but Black patients were not completing this year, much less than the white counterparts. So After talking about these two types of breast cancer, I want to focus on the hormone receptor positive breast cancer. That is my main focus on research and what I'm going to talk about in the rest of my talk. And what I want to focus on this. So hormone receptor positive breast cancer corresponds to the big majority of breast cancer. We're talking about 70 to 80% of all breast cancers. And it's more than 6 times than triple negative breast cancers, over 70 times higher than the HER2 positive breast cancer. And on this big group of patients, the big majority of breast cancer patients, Black women are 4 times more likely to die than their white counterparts. So the SWOG in 2009 decided to get all patients with breast cancer and said, okay, if all the patients we're getting here, we treat them in the ideal setting, does the disparity still exist? And they saw that they do exist in 2 settings. They're going to continue to exist if they are postmenopausal, and they're continue to exist if they are hormone receptor positive tumors. So there is a problem here on how we're treating these patients. And then the SWOG said, okay, we're looking at about Black patients, we're talking about white patients, but what about Hispanic patients? And Hispanic patients, what they saw was exactly the same thing. They didn't see difference in the hormone receptor negative group, but they did see difference in the hormone receptor positive groups. So what's going on there, right? In 2021, we had this big trial that it was the responder trial. It was a trial that helped us to de-escalate treatment. And those trials are always very interesting in breast cancer because our patients are living more, so we want to give them less treatment. And we were able to de-escalate treatment in postmenopausal women that they had this low risk score, and they were able to be treated with only endocrine therapy and not being treated with chemotherapy. So with that data, we changed how we treat our patients. We're giving much more hormonal treatment to our patients than chemotherapy. But then the SWOG did a subgroup analysis, and what they saw it was that among postmenopausal women, right, the women that are only receiving their endocrine therapy, non-Hispanic Blacks had worse disease-related free survival than non-Hispanic whites. And they adjusted that for treatment delivery and recurrence score. And non-Hispanic Blacks had a 37% increased risk of relapse than non-Hispanic whites, as well as lower distant relapse-free survival. So later, when I started to take a look at that, a lot of other groups also started to take a look at that. And we saw that there is a heterogeneity in response to endocrine therapy among races, right? Something's going on there. And it was at the ACR, there was this poster that I thought it was a very interesting poster that showed that race was a significant predictor for downstage. When endocrine therapy was given at neoadjuvant, it was a significant predictor of downstage on multivariate analysis, adjusting for duration of neoadjuvant endocrine therapy in clinical stage. And compared to white women, Black African-American women were more likely to, while on endocrine therapy, to be upstaged or reach stage 4 disease. And the backbone of treatment on these patients here was an anastrozole inhibitor, aromatase inhibitor, sorry, it's wrong here. Interestingly, we had here in Jackson reported that already. So that's why I wanted to highlight. So back in 2011 and 2019, we had already done this study on neoadjuvant hormonal treatment with postmenopausal women. And we highlighted how not only race, but also BMI was associated with response to neoadjuvant hormonal therapy, being high BMI in Black race significantly higher among non-responders group, the non-responders group. And the Black race was a negative predictor of disease-free survival in the setting of neoadjuvant hormonal therapy. So I talked about the Black race, but what about obesity? So Black women are more likely to be obese or severely obese in the US. Obese women are more likely to have worse breast cancer outcomes. So we had this big trial in the breast cancer environment, that it was the ATTACK trial. And that was a trial that actually guides us how we choose endocrine therapy for our patients, right? And it showed the superior efficacy and safety of anastrozole versus tamoxifen. So anastrozole is an aromatase inhibitor over tamoxifen that is a selective estrogen receptor modulator. And as initial adjuvant therapy for postmenopausal women with hormone-sensitive early breast cancer. But what I want to highlight here is a subgroup analysis of this trial that actually showing the anastrozole group and the aromatase inhibitor group, the hazard ratio increased as the BMI increased, and that was not seen in the tamoxifen group. So there is clearly a difference there related to the BMI. So what's my hypothesis and what I've been working on? I do believe that there is a worse response to the current standard treatment when compared to Black women to their white counterparts. And I believe that Black women and maybe obese women, they might require different and personalized hormonal treatment. I want to highlight that in treatment care, in chemotherapies, we do a lot of dose adjusted therapies to decide the dose of the medications. But on all these medications here, aromatase inhibitors and the tamoxifen, we use the same dose for everybody. And largely because we see that the patients enrolled on these trials that guide us how to treat were trials that were done in Europe with patients that have different body composition than the Black patients and Latin women, right? So I do believe there is probably an impact on the hormone and inflammatory milieu going on. I can be related to androgen receptor expression. I also have the hypothesis of the ESR1 mutation, the narrow gene pathway. I'm just going to expand a little bit on that, but I want to highlight that it's all ongoing study, and this is a hypothesis. So the hormonal inflammatory milieu, so we all know that obesity is associated with increasing total body aromatization and inflammation. White adipose tissue is known to release cytokines and increase cytokines such as IL-6, CRP, ESR, and all these cytokines, they upregulate aromatase expression. So if they're upregulating aromatase expression, maybe that's contributing for them to have resistance to that dose of aromatase inhibitors that we're giving. Androgen receptors are very common in hormone receptor tumors. Androgen receptors and hormone receptor positive breast cancer are usually small tumors with lower histological grades, less aggressive. And there has been a number of population-based studies that support the hypothesis that androgen receptors may antagonize the detriment effects of ER signaling. And maybe there is this inverse association between tumor AR expression and mortality among hormone receptor positive breast cancers. But we do not have any type of data on AR expression regarding race and obesity and BMI. ESR1 mutations became very relevant because it's a mutation that it's not happening in all the patients when they are treatment naive. It's a mutation that surges when you start them on treatment with aromatase inhibitors. But nowadays FDA has approved a drug for that. It's the elacestrant. With the Emerald trial, we can treat patients with that mutation. So maybe Black patients are developing that mutation early on in the treatment than white women. We don't know if there is any difference on that related to race. So this is my ongoing trial. We had talked when you introduced me, you already talked. What I've been studying is actually hormone receptor positive breast cancer in postmenopausal women, and I'm trying to evaluate all of these pieces of this puzzle in what I can impact, right? This is all ongoing with the support of the Conquer Cancer Foundation, BCRF Foundation, and it's a prospective study. Hopefully, we'll be able to present some of our studies in San Antonio this year, but this is a little bit of what I've been dedicating my time. In why Miami? I just want to highlight, we are very privileged here in Miami with the population that we have access to. Our patients, we have access to this very diverse population, patients from all over the world. And I believe that being able to study disparities here, it's not only feasible, what it's not in many places, but it's also a must. We have this responsibility because these are our patients. So if that's going to impact how we're going to treat them, we should actually dedicate our time for that. And just want to highlight that hormone receptor breast cancer, because it's such this big group of patients, if we have at least a little bit of impact, it doesn't need to be a huge impact, but that can already create a big impact. I want to say thank you all and say that nothing of this is possible without support, right? So support. Thank you to my mentors and my teammates.
Thank you, Dr. Maya. It's so nice to see you on this side of the podium, indeed. And this represents a great deal of work. Thinking about the future and thinking about how you'll get funding for looking at these problems initially, how would you propose your applications to the NCI now in terms of making them more appealing for funding? The need is clearly there. How are you thinking about that for your future?
So yes, And that's something that has been, we've all been talking about that. But this is not something that's going to bring only improvement for DEI. I don't see that as a DEI project. This is a population-based project. Like I said, the numbers here in the US are increasing, right? So we're not focused only on that. We're improving care and improving the survival of all our patients if we get to a point that we can deliver a more personalized medicine to them. So that's how we've been doing.
Great. Okay, thank you
Yeah.
very much and good luck.
Thank you for that wonderful talk. It's my honor to introduce today's second speaker, Dr. Omar Wever-Pinzon. He is the director of the Advanced Heart Failure Treatment and Recovery Section at the University of Miami Health System and Jackson Memorial's Miami Transplant Institute. A board-certified specialist in advanced heart failure and transplant cardiology, he has extensive expertise in cardiomyopathy, heart failure, transplantation, and mechanical circulatory support, including LVADs. Dr. Wever-Pinzon earned his medical degree from the Universidad de Panama and completed advanced training at the University of Utah and New York Presbyterian Columbia University. Previously an associate professor at the University of Utah, his NIH/NHLBI and VA-funded research focuses on cardiac failure, recovery, and advanced support technologies. He has also led numerous clinical trials on innovative heart failure therapies. An accomplished educator and researcher with numerous publications, Dr. Wever-Pinzon founded and directed the Inherited Hypertrophic Cardiomyopathy Program. His research and leadership and expertise will drive advancement in patient care, research, and education at the University of Miami. Please welcome Dr. Wever-Pinzon.
Thank you for the kind introduction. So I have worn many hats in the past, and today I'm not going to talk about my NIH funded research because we will have an invited speaker in the future that will talk to us about recovery. He's my mentor. So today, I'm going to talk to you a little bit about my experience with our hypertrophic cardiomyopathy program, particularly how the treatment paradigm in patients with this condition is evolving. So first, okay, so our learning objectives, you learn how to identify HCM, a little bit about the epidemiology and how to evaluate these patients, and more importantly, how the treatment paradigm is changing in these patients. So HCM is not a rare disease anymore. But it's a widely underdiagnosed disease. As you can see here, this is work from Dr. Maron's group. In this registry data, HCM was identified in about 125 countries, which represent 90% of the global population. When we talk about the prevalence has been now revised based on our improvements in genetic testing and our improvements in cardiac imaging, echo contrast, cardiac MRI. We know that from the typical prevalence of 1 in 500 based on the cardiac study, now it's down to anywhere from 1 in 200 to 1 in 500. Based on this, HCM is estimated to be in 15 to 20 million people worldwide. And from those, about 1 million in the United States. Reality is that we're dealing with the tip of the iceberg. Only 100,000 patients with HCM have been identified. So the vast majority of patients with HCM are walking around with the disease and they don't know it. That's the reason this is important to know. Now, when it comes to the HCM and the etiology, we know that the genetics of HCM, the typical monogenic approach, and we know that this is true, it's an autosomal dominant inheritance, which involve over 8 genes that involve the sarcomere and the C disc. Over 2,000 mutations have been identified, with most of those mutations being missense, meaning there's a change in quality of that protein, with some mutations being truncating variants, which leads to haploinsufficiency or deficiency of the protein itself. These are the most common variants, but if you memorize the myosin binding protein C3 and myosin heavy chain, you'll know the vast majority of the mutations. Now, we always have to keep in mind the phenocopies, right? Amyloidosis being one of those. Now, through this monogenic hypothesis or approach to HCM, it doesn't fully explain all the characteristics that we see in HCM. For instance, we see patients that develop an apical aneurysm. We see patients with regional LVH. We see also involvement of the small vessels. Why the mitral valve apparatus is also abnormal with elongated mitral valves, anomalous position of the papillary muscles, and myocardial fibrosis. So this monogenic approach, it doesn't fully explain anything, everything that we know about HCM. So is it possible that there are modifying genetic variants, polygenic risk, right? Are there environmental factors? And we're learning more about the environment affecting gene expression in these patients. And also, is there a role for epigenetic modifications and post-translational modifications? So a lot to be learned when it comes to genetics. But what we use to genetic today is going to change in the future. Right now, at this time, we use genetic testing, genetic mutation information for confirmation of the diagnosis and also family cascade screening. But these are things that are coming in the future. We can re-stratify. Hopefully, we will be able to re-stratify patients based on a risk scores, polygenic risk scores, and but more importantly, we'll be able to target therapy. And this is already the efforts to create this type of approach, therapeutic approach, are already ongoing. And I'll show you some information on that. All right, so at the end of the day, the gene mutations lead to sarcomere dysfunction. There's an impaired active myosin interaction in patients with HCM, right, that leads to sarcomere dysfunction. You see that the normal sarcomere has a normal ratio or proportion of super relaxed state of the active myosin, right? And that leads to the normal contractility and effective relaxation. Now, in a sarcomere, patients with HCM, you see that proportion of active myosin cross bridges, right, is enhanced. That leads to hypercontractility, which is typically what you see when you read your echoes and your MRIs. This is what you get. That hypercontractility, there's also impaired relaxation. You think about it, if this active myosin, these cross bridges are always, engaged, the heart cannot fully relax. So that leads to impaired relaxation. That leads also to increase in ATP consumption, so abnormal energetics or ATP depletion. We're not fully clear on what are the secondary signaling that occurs that leads to myocyte hypertrophy and fibrosis, but we do know that it's triggered by the abnormal energetics in patients with HCM. And there's a reason for that. But at the end of the day, all these changes that happen at the molecular level, they lead to hypertrophy. Right, that hypertrophy, and for our medical students and residents, right, this is a typical diagnosis. This is a diagnostic criteria for HCM. It's left ventricular hypertrophy that cannot be explained by a secondary or systemic disorder, right? Well, how much is LVH? Well, LVH more than 15 millimeters, and if you have a family history of positive genetic testing, then we lower the threshold to 13 millimeters. Now, you do not need genetic testing positive to have the diagnosis, but it's nice to have that confirmation as well. Now, all this is evolving as well, and in the next set of guidelines, we'll see, as you can see here, this is an example of a study that was done by Hughes and colleagues, where they look at the performance of our standard criteria greater than 15 millimeters and they compare this by indexing the wall thickness in patients with apical HCM. And you can see that the bottom line is that the diagnostic accuracy of the new criteria, the modified or personalized criteria, improved to 92% from 69%. So a lot is changing in the field. Now, at the end of the day, as I said, hypertrophy can present in different flavors, and this is a typical degree of hypertrophy that we see in HCM with asymmetric septal hypertrophy, but the patients can present with concentric hypertrophy, which it can mimic amyloidosis, hypertensive heart disease. It could be a diagnostic challenge, right? We can have focal areas of hypertrophy and this, or also apical hypertrophy, apical HCM. At the clinical level, hypertrophic cardiomyopathy is also very diverse, with 25% of the patients experiencing AFib, heart failure, ventricular arrhythmias, and overall increased MACE or major adverse cardiovascular events. Right, patients present with symptoms as described here can present as an incidental finding with EKG. But at the end of the day, when that patient is in front of you, you want to assess or classify the patient. Is this a patient with obstruction or no obstruction? And this is important because there are differences in treatment, including the new treatments that I will discuss with you, right? So, and we do that with echocardiography, where we essentially measure the pressure gradient at the level of the LVOT. The pressure gradient is greater than 30, then the patient is obstructed, as you can see an example here where the patient has obstruction to the flow, and if it's less than that, the patient is not obstructive, and again, there will be a difference when we approach these patients. You have this in your form, so I'm not gonna go over the case in the interest of time, but I will go over all the things. And the point in this clinical case is that it is important for us when the patient presents to your clinic to really try to make sure is the patient truly obstructive or not. Because 1/3 of the patients will present with obstruction at baseline, 2/3 of the patient will have no obstruction. But of those 2/3, there's 1/3 of patients that if you do provocation maneuvers, that patient group will have obstruction. And it's important as they have different prognosis, different paths, and again, different ways of treating it. These are some examples of provocation maneuvers. So, but what are the factors that lead to LVOT obstruction, right? When the heart ejects, you have the normal blood flow, right? The blood leaves the heart through the LVOT, so no issues. Now you see here that there's elongated mitral valves longer than the normal heart. The papillary muscles are located anteriorly, and the septum redirects the blood flow, which pushes the valve from behind and leads to the obstruction, right? So again, these are the substrates that contribute to that obstruction. Now, activities of daily living that will increase obstruction include hypovolemia, dehydration, so decrease in preload, Valsalva maneuver, which is functionally decreasing the preload, alcohol, which also decreases the blood return to the heart, and large meals, and obviously increased heart rate. The negative consequences of LVOT obstruction, you have that obstruction increases your LV systolic pressure, workload, supply-demand mismatch, ischemia, which leads to symptoms, right? Also decreased relaxation, decreased LV filling, decrease in the stroke volume and cardiac output, which is gonna lead again to symptoms. Mitral regurgitation, which is associated also with the systolic anterior motion of the mitral valve, and increase in left atrial pressure is also gonna lead to symptoms and pulmonary hypertension. Okay, from the clinical perspective, it is important to know that obstruction can affect the patient, and you can see how the patients with obstruction, they have increase in ACM-related death, also increased rates of sudden cardiac death, and also decompensated heart failure. Importantly, once you fix that obstruction, and this is a study where a patient had underwent myectomy or alcohol septal ablation, right? The ACM-related death improves. That being said, there's a group of patients that continue to still have heart failure endpoints, as you can see here, despite relieving that obstruction. So why that is? So that gives us a segue to the next group of patients that I want to discuss, which is patients with non-obstructive HCM. And you can see here that most patients will have very mild symptoms, while 10% of the patients will have significant NYHA class 3 to 4 symptoms. So this group of patients will have increased mortality, increased rates of heart transplantation, and sudden death. So let's look a little bit into the group of this group of patients. So this was a study performed by one of my co-fellows many years ago, where he looked at these patients with non-obstructive or subbasal HCM, and he looked, okay, what are the characteristics of these patients and what correlates with high symptoms? And you can see here that the prevalence of subbasal HCM within the whole cohort was 5%. Half of those patients, almost half of those patients, they have advanced symptoms. So what were the phenotypic characteristics of those patients that led to symptoms? You can clearly see that these patients have so much hypertrophy that they really don't have left ventricular and diastolic volume. Also, those patients that have apical or mid to apical HCM will develop an apical aneurysm, where patients also have increased symptoms and increased risk for sudden death. So decreased left ventricular and diastolic volume, stroke volume, and cardiac output correlates with symptoms, also the presence of an apical aneurysm. And these are some examples of patients that I have in my previous program, where you can see patients with apical HCM, very small cavity, and you can see here the marker, the hemoglobin A1C of diastolic dysfunction, that left atrial side that is huge, right? That tells you that the patient has chronic left ventricular diastolic dysfunction. You see another patient with a lot of fibrosis by cardiac MRI, LGE, that tells you that this patient has increased risk for sudden cardiac death. So within the traditional treatment paradigm in patients with HCM, the patients with LVOT obstruction, they were treated with beta blockers, calcium channel blocker, right? What was the reason of that? It was to decrease the heart rate, improve filling time, and that's why I explained to you the basics of obstruction in terms of hemodynamics. Also, disopyramide, even though disopyramide is an antiarrhythmic, it's a very potent negative inotrope, right? And that helps with the obstruction, as you saw. Septal reduction therapies, meaning septal myectomy or alcohol septal reduction, were used also in patients that did not respond to medical therapy. When the patient has ventricular arrhythmias, the patient we treat with antiarrhythmics, the patient needs an ICD. And in the interest of time, I won't talk about risk stratification of sudden death, but happy to answer any questions at the end. Patients with atrial fibrillation, we use anticoagulation, rate, rhythm control strategies, and it's important to know that the CHA2DS2-VASc score in patients with HCM does not apply. The patients at HCM who develop atrial fibrillation have a high 8-fold increase in the risk for stroke and thromboembolic events. So patients with HCM and atrial fibrillation warrants anticoagulation regardless of any risk scores. A group of patients will develop heart failure, as you saw, and in those cases, we use medical therapy and transplantation. And in a very select cases, we could use mechanical support, although that's a less common scenario. Now, when we talk about a traditional treatment paradigm, we see that there are limitations with this, right? It's really focused on symptom management. It is started late in the disease course. It is non-specific and cannot modify the disease, and really is based on very limited to no data, right? The only agent that has some data is the beta blockers, which is based on retrospective studies. So there are unmet needs when it comes to the management of patients with HCM, right? We need to eliminate the symptoms, we need to avoid invasive procedures, and we need to aim to modify the disease itself. So, and here's where it comes all this sarcomere talk, and why I was showing you the sarcomere is because now, understanding the molecular basis of the disease, we have targets for HCM therapy, where we can target the gene mutations themselves, we can target the actin-myosin interactions, we can target the energy substrate, we can target also that secondary signaling that leads to the hypertrophy and fibrosis, right? So there are drugs that are doing that now. And the first group of drugs that I'd like to discuss with you is the use of cardiac myosin inhibitors. So how do they work? The myosin inhibitors, they selectively inhibit the cardiac myosin. They decrease the actin myosin cross bridges, right? And they change that sarcomere from that state of hypercontractility, impaired relaxation, and abnormal energetics to a more normal sarcomere with this attenuated contractility, improve relaxation, improve energetics, which if you think about, it could have long-term impact. And again, you have this in your package for MOC questions, so I'm not gonna go over this, but this is, again, a question with about mavacamten. So mavacamten is the first myosin inhibitor that has been studied in patients with obstructive HCM, right? It was a study in the Explorer-HCM trial, which was a phase 3 randomized control, placebo-controlled trial with patients with symptoms as significant obstruction, right? Significant obstruction determined by a gradient greater than 50, right? The primary endpoint in the Explorer trial was an increase in peak VO2 greater than 1.5 with an improvement in NYHA class of at least 1, or an increase in peak VO2 greater than 3 without worsening in NYHA class. And you can see here that in the mavacamten group, 30% of the patients achieved that primary endpoint compared with only 17% in the placebo group, right? And when we look at the individual components of that primary endpoint, you can see that it was significantly better for patients taking mavacamten in all the components of the individual endpoints, including this group of patients that I like to call the super responders, where they have improved in peak VO2 greater than 3, and also an improvement in NYHA class by at least one class. Again, it was significantly superior in patients taking mavacamten. What about on the effects of LVOT obstruction? You can see that the patient at the beginning, at rest, Valsalva, and exercise, they have significant obstruction, a gradient of 50, 75, 80, and you see that mavacamten compared with placebo was able to significantly reduce that obstruction in all the patients. What about effects on the symptom burden? You can see that after 30 weeks of treatment, compared with baseline, the patients taking mavacamten, 50% were in NYHA class, compared with only 21% in the patients in the placebo group. You can also see that the NYHA class 3 patients, how there was a significant reduction in NYHA class 3 patients in the patients taking mavacamten compared with the placebo group. When we also look at patient-reported outcomes type of measurements like KCCQ and HCM-specific questionnaire, there was also a significant improvement in the quality of life of these patients by the use of mavacamten, right? So mavacamten has always been has also been studied in patients with more symptoms, and this was addressed in the Valor HCM study, where patients with NYHA class 4 symptoms were studied, and the purpose of the study was to determine can septal reduction therapy, can myectomy be avoided? And for this, patients were followed for about 30 weeks. They were followed monthly by a surgeon, by a cardiologist, and we determined the patient remained eligible, meaning very symptomatic NYHA class 4 symptoms, and they still had a gradient above 50, right? And you can see that mavacamten compared with placebo, only 18% of the patients remain eligible at the end of the study for myectomy versus 77% in the placebo group. So it significantly improved the proportion of patients. So it is very effective. This is the long-term follow-up of those patients, and you can see that the gradients and the amount of patients that also remain eligible it's very low. And at the end of those 56 weeks was less than 10%, which is even better than the original trial. Now, the results showing with mavacamten has also been shown with a new drug, which is called aficamten. Aficamten is a new myosin inhibitor, which has better pharmacodynamics and kinetics with a half-life of 3 to 5 days, as opposed to 9 days with mavacamten, which makes it easier to titrate the medication, and it seems to have also less interactions with medications and also a better safety profile. With decrease in the ejection fraction only in 3% of the patients versus 7% of the patients taking mavacamten. And again, they assessed this in a phase 3 trial called the Sequoia trial, and you can see that the primary endpoint, which is the change in peak VO2 uptake, was significantly improved in patients with mavacamten by 1.7 ml/km compared with 1.4 ml/km in patients in the mavacamten study. That being said, that's not a head-to-head comparison, but there was a significant improvement, right? There was also improvement similar to what you saw in the Explorer trial compared with placebo at the end of those 24 weeks. Aficamten significantly improved obstruction, right? And also improved NYHA functional class. You can see at the end of those 30 weeks how in patients with aficamten, 60% improved at least one class versus only about 20% in the patients in the placebo group. When we look again at KCCQ, also there's a significant improvement in quality of life by this PRO metric. Now, this is for patients with obstruction. What options do we have for patients with non-obstructive HCM? Myosin inhibitors have also been studied in patients with non-obstructive HCM, and this was tested in a study that we run called the Maverick HCM trial. This was a phase 2 trial looking at safety mostly, but we also assessed some efficacy endpoints. Patients were symptomatic. They had normal EF. They had also evidence of congestion by elevated NT-proBNP. They were randomized to low dose and high dose of mavacamten based on PK compared with placebo. And the bottom line of this study, we saw that overall, there was a similar proportion or a greater proportion actually of serious adverse events in patients in the placebo group. And there was a 12.5% reduction in LVEF, which normalized in all patients when mavacamten was discontinued in this trial. When we look at the efficacy endpoints after those 16 weeks that the patient were followed, there was a significant decrease in NT-proBNP and also cardiac troponin, which is used as a marker of overload or pressure overload injury to the myocyte. Okay. Unfortunately, mavacamten was tested in the Odyssey HCM trial, and the results were released, not completely released, but there was announcement by the investigators conducting this trial. In this trial, there was a follow-up of the Maverick trial, a phase 3 trial, bigger trial, with the endpoint, again, was looking at change in peak VO2 and also KCCQ questionnaire changes, and the trial was negative. Aficamten was evaluated also in this patient cohort in the Redwood HCM trial in patients with non-obstructive HCM. Similar characteristic with preserved EF, evidence of congestion, right? And overall, it showed that aficamten was safe with only 7% of the patients having a drop in LVEF, which was reversible, right? And there was a similar decrease in the NT-proBNP and also in the levels of cardiac troponin after 10 weeks of treatment. There was also significant improvement in KCCQ scores and also in NYHA class by these drugs. Now, these drugs are already showing that there could also be a potential in reverse cardiac remodeling. And this is data from the cardiac MRI sub-study of patients in the Explorer HCM trial. And you can see that there was a significant decrease in the mavacamten group in the wall thickness, LV mass index, left atrial volume index, a marker of diastology again. There was no change in fibrosis, and there was just slight change in LVEF. So similar results we're seeing with the Sequoia CMR sub-study. Okay, so this is the landscape of the myosin inhibitors and all the trials that have been performed in patients with obstructive HCM, non-obstructive HCM, and there are different agents that are being evaluated, and we will see some of those trials here at the University of Miami. Another group of medications I'd like to discuss is the metabolic modulators, right? So now we're targeting the energy substrate, right? So the mechanism of action of these agents to shift metabolism from fatty acid oxidation to glycolysis, right? By doing that, we create a more efficient way of generating energy. With glycolysis, you produce more ATP by molecule of oxygen. So one of the agents that had been tested in this group was perhexylene, which is a carnitine palmitoyl transferase 1 inhibitor, right? Which again shifts fatty acid oxidation towards glycolysis, and that improved the peak VO2 functional capacity, the phosphocreatinine to ATP ratio, and also the PRO Minnesota Living with Heart Failure questionnaire. Also improved relaxation time and contractility overall. This was a phase 2 trial. The 9-Rafaxtat or IMB 101 was a study that was tested in a phase 2 trial in the Improve HCM trial, which we participated in my previous institution, and essentially has a similar mechanism, again, shifting to glycolysis from fatty acid oxidation. We noticed that there was an improvement also in functional capacity, VE, VCO2 slope, in patients with non-obstructive HCM. So based on this, the phase 3 trial is being developed, and this is a trial that we are actually onboarding here at the University of Miami in the upcoming months. Gene therapy. So gene therapy is another treatment modality where there are different CRISPRs, gene editing, gene replacement, RNA-based therapy, and a multitude of therapies that are being used and tested in the clinical arena in patients with HCM. But this is the one that has great advancement at this point, which is gene replacement therapy using a vector, which is adeno-associated virus 9. And this is being tested in humans now. This is this is data from my study, where you can see that gene replacement therapy in patients with truncating variant of myosin binding protein C3, right? Patients, or not patients, but mice that were treated with this vector, there was an increase in the normal gene expression. There was suppression of the mutant gene expression. There was also significant improvement in LV mass. This was proportional with dosing. There was an improvement in relaxation, force generation, and contraction velocity, right? So the MIC-PIC1 study is a study that is being conducted right now in humans with different phases. It is ongoing so far. There have been 2-3 patients that have been enrolled without any major side effects. The good news is that not a lot of the population has antibodies, which is important to the vector. And we are able to test or try to use this in the future in patients with this type of mutation. Another group of medication that has also been tested in patients with HCM is TGF-beta pathway inhibition, where we're trying to prevent fibrotic gene expression and hypertrophy. And this was tested in the Vanish trial, where we tested we can attenuate disease progression. So valsartan was tested in a randomized controlled trial using a composite C-score as the primary endpoint. And patients with very early HCM were tested. They have very mild hypertrophy, preserved EF, no obstruction, very mild symptoms. And in the bottom line, we saw an improvement in the composite C-score, which include markers that tell you about remodeling of the heart, wall thickness, mass, volume, left atrial volume, and diastolic markers. So the new treatment paradigm in patients with HCM is changing, right? We go from just treating the symptoms to trying to modify the disease, and where we can tackle sarcometic mutations with all these technologies that you see here. We can tackle the primary effects of hypertrophic cardiomyopathy with myosin inhibitors, metabolic modulators. We can tackle secondary signaling with valsartan, supported by the Vanish trial. And there's a lot more to learn about, again, how the environment impacts gene expression or disease expression, I should say, in patients with this condition. Right? And I foresee that in the future, we'll be seeing something similar to what we do in heart failure right now, where we use the 4 pillars, right? Where we may need to use myosin inhibitors, metabolic modulators, right? Secondary signaling and other therapies to try to identify, to modify comorbidities like obesity and hypertension to try to achieve the desired outcomes in patients with HCM, right? So in summary, HCM is a complex and diverse disease. Stratification based on the presence of obstruction is the first step in the approach to these patients. And an improved understanding of the genetic and molecular basis of HCM has helped to develop novel therapies in this group. Thank you.
Thank you, Dr. Pinzon, for compressing a lot of information in a short period of time. It was very interesting. In the studies done with the myosin inhibitors and maybe even any of the other modalities which are so exciting, has any of them been shown to actually prolong life in patients with congestive heart failure for this cause?
Yeah, so thank you. No, we're not to that point, and that's actually one of the questions that we put there in the MOC. So all these studies have shown improvement in functional capacity, decreased symptom burden, reverse remodeling, but there's no survival benefit at this point. All of these patients that are included in the different trials that are being followed in the long term, but we're not there yet today to answer that question.
Any questions from anybody in the room? There's some in the chat. I'll ask you, is that Dr. Martinez? Do you want to unmute yourself and ask your question? Was it Claudia or no?
No, I think
Sorry,
the answer is.
I just see your camera. Dr. Zawid, do you want to unmute yourself and ask your question? I'll read it. Can these drugs be used to treat Duchenne muscular dystrophy with cardiomyopathy?
It's a great question. They have not been tested in that population, and the mechanism of disease in the Duchenne muscular dystrophy population it's different. And these patients tend to develop more of a dilated cardiomyopathy phenotype as well. So these are drugs that would not be actually safe in patients with Duchenne, probably.
Thank you very much. I thank all of our participants today in the room. Please check the chat or as you exit for the MOC and CME credits. I look forward to seeing everybody next week and have a wonderful week. Thank you, Dr. Pinzon.
Thank you.
Thank you.